Arteries, capillaries, and veins form a network of several thousand miles of passageways leading to virtually every part of the body. The only body structures that lack a blood supply are mature cartilage, the cornea and lens of the eye, membranous epithelium, and epidermal derivatives including hair and nails. Arteries are the blood vessels that transport blood away from the heart. Veins carry blood back toward the heart. Capillaries are the microscopic vessels between the arterial and venous channels. They are the functional vessels involved in the exchange of nutrients and wastes between blood and other body tissues. Blood is the only fluid tissue in the body, and it serves as the transport medium of the cardiovascular system. It is the only tissue that functions as a major component of the body without being part of an organ.
Hi, I'm Mike Shively. Welcome to Introduction to Anatomy and Physiology. In a previous session, we introduced the cardiovascular system and talked a little bit about the heart, cardiology itself. In this session, I want to talk about circulation and a little bit about blood vessels. So, anybody have a question from previous session? Amber?
Yeah, I was curious as to how pacemakers work in the heart.
Pacemakers are artificial devices that electrically stimulate the heart when the heart's own electrical system is failing to function properly. Let's go to the overhead camera for just a second. Maybe you can remember from our previous session, we talked about up here in the wall of the right atrium a group of specialized cardiac muscle cells that we called the SA node, sinoatrial node. Those are the normal biological pacemaker cells in the heart, and they determine heart rate. The electrical impulse spreads throughout both atria from that location. And then there's another group of these specialized cardiac muscle cells located about here called the atrioventricular node, AV node, it's often acronymed. And the job of these particular modified cardiac muscle cells is to slow the impulse or delay the impulse a bit in order to allow the atria to complete their contraction before the ventricles begin to contract. At any rate, these, if the SA node or AV node are not working properly in their jobs, sometimes the ventricles are inadequately stimulated to contract. And so artificial electrical devices are installed into the heart in order to cause the ventricles to contract. Remember, the atrial contraction is not particularly important to cardiac function, but ventricular contraction is very important to get the blood pumped out to the various parts of the body. Any other questions, Bryce?
So where do they put those when they install them?
The actual device itself is usually installed in a subcutaneous position up here on the chest wall, but the electrical leads, little wires, feed down into the heart itself. So that we need to change a battery in the pacemaker. It's a relatively minor procedure. My father had one of these installed in 1983. And still has the same battery. It's a demand pacemaker that only turns on whenever his heart is functioning improperly. And so he's got a little Duracell battery in there that's still working. Any other questions? Bryce?
So like the security gates and at the airports and whatnot, do those have effect on the pacemakers?
You know, I don't believe they do. I know that people with pacemakers are advised against staying real close to microwave ovens when they work and that sort of thing, but I think they've got most of that under control now. Any other questions? Starley?
Sorry, when they shock someone after they've, what does that do to the hearts? I mean, is it within, like, those SA and B nodes stopped working and so you're just jumping those?
Starley, have you ever been so far into your computer that you were so messed up that you couldn't even get out back to where you wanted to go, and so you basically shut it down and rebooted, okay? Yeah. When they do that to, you know, call for the, you know, the blue light comes on or whatever it is, blue light special on the floor, and they actually put those paddles on somebody's chest, the heart is probably in a state of what they call fibrillation, where it's different parts of the heart are contracting at different times. Basically, this electrical system is messed up, and by blasting it with direct current, they'll basically cause it to shut down for a second, and then hopefully it'll reboot and start again on its own with a normal rhythm. That's exactly what they do. All right. Today I want us to distinguish, first of all, the difference between systemic circulation and pulmonary circulation. What do we mean by systemic circulation, the concept, the idea? Susan?
The systemic circulation is the circulation that goes from the heart to all parts of the body and then back into the heart.
Okay. When we say systemic circulation, I want you to think heart to most of the body and back to the heart. And then pulmonary circulation, Susan, would be what?
That's the circulation that goes from your heart just to the lungs and then back again to the heart to
So from
oxygenate.
heart
Right.
to lungs and back to the heart would be what we mean by pulmonary circulation. Let's go to the overhead camera and draw our heart. We'll be drawing a lot of these hearts. And we'll put a little X in here and label this. This would be RA, standing for right atrium, RV for right ventricle, LA, Los Angeles, and LV for left ventricle, okay? Now, coming out of the left ventricle, one big artery. What's the name of this artery? Single large artery coming out of the left ventricle. Adam?
The aorta.
Aorta. Now, the aorta carries blood to most of the body. And after going through capillaries in most of the body, that blood returns back through a couple of large venous channels into the right atrium. Heart, most of the body, right atrium. That's the systemic circulation. Coming out of the right ventricle is a single, very large artery. Now, why is this an artery? Because it's carrying blood, what? Away from the heart. Anybody know the name of this large artery coming out of the right ventricle? Starley?
The pulmonary trunk.
This is the pulmonary trunk. And the pulmonary trunk carries blood from the right ventricle to the lungs. So we'll write lungs right here. And then that blood returns back to the left atrium through 4 pulmonary veins. Right ventricle, lungs, left atrium. This is the pulmonary circulation. So heart, body, heart is systemic. Heart, lungs, heart is pulmonary circulation. Let's go to a couple graphics that summarize what we just diagrammed. First graphic here talks about the systemic circulation. Starting in the left ventricle, goes to the body and back to the right atrium. The arteries carry high oxygen blood and the veins carry low oxygen blood. In the next graphic, we summarize what we mean by pulmonary circulation. Starting in the right ventricle, we carry blood to the lungs, back to the left atrium. The arteries carry low oxygen blood, and the veins carry high oxygen blood. Any questions about what we mean by systemic circulation and pulmonary circulation? Susan?
So veins don't always have low oxygen blood and arteries don't always have high oxygen blood. I think
That is a common misconception, Susan. The reality is that the systemic arteries carry high oxygen blood and the systemic veins carry low oxygen blood. But if we get into the pulmonary circulation, the pulmonary arteries carry high oxygen blood and low oxygen blood, the pulmonary veins carry high oxygen. I think the important thing for you to remember when you try to keep these straight is the fact that the oxygen level of blood only changes in capillary beds, okay? So it changes in the capillary beds of the lungs, and when you think blood's going to the lungs to what? Dump off carbon dioxide and pick up CO2. So the arteries carrying blood from the heart to the lungs are going to be carrying blood that has low oxygen level. But the veins draining out of the lungs and carrying that blood back to the heart are going to have blood that has high oxygen content. And just exactly the opposite is going to be true on the systemic side of the circulatory pattern. I want to talk about arteries for just a little bit. Let's go to the overhead camera. I'm going to write the word artery up here. And I want us to remember that there are 3 sizes. These come in large, really small, and everything in between. Now, the very biggest arteries are called elastic arteries because they have a lot of elastic connective tissue in their walls. AA is the abbreviation for arteries. The in-between arteries are called muscular arteries because they have a lot of smooth muscle tissue in their walls. And the really tiny arteries are called arterioles. The only elastic arteries in the body are the aorta, the pulmonary trunk, and some of their largest branches. Most of the arteries in the body that you can see are indeed muscular arteries. Arterioles are very, very tiny. The biggest ones we can see with the naked eye, the smallest ones require magnification. These are the blood vessels that feed blood into capillaries. So capillaries never arise from elastic arteries nor from muscular arteries. Only the smallest arteries, called arterioles, feed blood into capillaries. Now, when we take a look at the structure of an artery, there's actually three basic layers to the wall. On the outside, called the tunica externa, it's CT proper. I'm just going to write CT proper, and I'm going to write the word in parentheses on the outside. Tunica externa is actually the Latin name for that outer layer of CT proper. And then most of the wall of the artery is called the tunica media. And structurally, that middle layer, tunica media, is elastic CT. It's got a lot of elastic fibers in it. And smooth muscle tissue. I'll write T for tissue here. So tunica externa, tunica media, and then there's a very, very thin lining on the inside that's called the tunica interna, or tunica intima sometimes. And that's a thin layer of simple squamous epithelium. I'm going to write SSE, simple squamous epithelium, that lines the very inside of the vessel. Now, arteries of different sizes vary primarily in this middle layer. So these large or elastic arteries have a lot of elastic connective tissue. They still have some smooth muscle tissue. The muscular arteries have a lot more smooth muscle tissue, less elastic tissue in their tunica media and so forth and so on. Now, the functional responsibility of these very, very largest arteries, the ones that we call elastic arteries, is to actually, when the heart contracts, these vessels swell out. They bulge out, get bigger in diameter a bit. And then when the heart is in diastole, when it's in the relaxation phase, the elastic arteries undergo what we call elastic recoil, and they shrink back down. So they swell up when the heart contracts, they shrink back down. The purpose of this is to keep the blood pressure from going off the scale during cardiac systole and dropping clear down through the floor during diastole. You know, without the elastic arteries, the blood pressure would be doing this, going way up and way down for systolic pressure and diastolic pressure. With the elastic arteries, the blood pressure goes up some and comes down some, but it doesn't go up as high as it otherwise would, and it doesn't come down as low as it otherwise would. Any questions about that? It's basically the same as shock absorbers on your car. Here's your car with springs only. And here's your car with springs and shock absorbers going over a rough road, okay? The muscular arteries, that second set, the kind of the medium-sized ones, if you will, it's their job to distribute blood to different parts of the body. I mean, if you're going to go start working out down the gym, you're going to have more blood flow into what? Your skeletal muscles. If you just ate lunch, you're going to have more blood going to alimentary canal or digestive organs and so forth. And they also control the overall blood pressure. So distribution of blood throughout the body and control of the overall blood pressure are the two functional responsibilities of the muscular arteries. And then I've already mentioned the functional role of the arterioles is to feed blood directly into capillaries. All right, let's take a look at some of the big arteries. I'll bring a model up here, and we'll go to the overhead camera and take a look at this model. We've seen this model before. This is the aorta, and it's a very, let me pull the front part of this heart off and set it aside so we can see the aorta originates here from the left ventricle. The aortic valve would be in this location. And then the aorta itself is divided into an initial part that's carrying blood upward toward the head. It's called the ascending part of the aorta. And then there's kind of an umbrella handle loop here that's called the aortic arch. And then this is the descending aorta that continues on down, goes down through the thorax, down through the abdominal cavity, and finally divides down there into a couple of terminal branches. Now I want you to notice that this initial part, the ascending aorta, has only two branches, and they're stubbed off on this particular model. Those are the left and right coronary arteries that carry blood directly to the heart. I want you to realize that even though these chambers of the heart have blood within them, the tissue out here in the heart wall cannot be fed by this blood in here because the nutrients and waste products cannot diffuse through that kind of distance. So the heart has blood vessels within its substance. Matter of fact, blood vessels themselves have blood vessels within their walls. They have very, very tiny blood vessels within their walls because except for capillaries, blood vessels have walls that are too thick for diffusion of oxygen and other nutrients and CO2 and other waste products. Okay, two branches of the ascending aorta. There are three branches of the aortic arch. These go up to head and superior limbs. They have particular names. We won't go over those names. And then the descending aorta, which comes on down this direction. Let me get a different model up here. And I just want to show you a different model. I believe we can see at least some of this on camera. I'm going to hold it like this and go to the overhead camera, and let's take a look. Here's the ascending aorta, the aortic arch, and here comes the descending aorta down through the thoracic cavity, comes down through the abdominal cavity, and here it splits into a couple of terminal branches. This very bottom end where the aorta divides into these two vessels is called the aortic bifurcation. And these two terminal vessels happen to be the left and right common iliac arteries. And so you can see on this model there are various branches coming off at different locations that are supplying organs along the way. So that basically shows the general pattern of the aorta in its major branches. The pulmonary trunk, that big large artery that's supplying the pulmonary circulation, comes up and simply splits into left and right pulmonary arteries. The left pulmonary artery carries blood to the left lung, and the right pulmonary artery carries blood to the right lung. Then after the blood goes through capillary beds in various body organs or in the lungs, then that blood returns back to the heart, whether we're talking systemic circulation or pulmonary circulation through venous channels. Now, let's go to the overhead camera for just a moment. I want to talk about veins for just a sec here. I want you to think of veins structurally as thin-walled arteries. They have the same three layers to the wall. There's a tunica intima and a tunica media and a tunica externa. So they're like arteries, except they have thinner walls. And if I were to draw an artery-vein pair, we'll say this vessel is the artery, thick wall, relatively smaller lumen, and the venous channel that would be accompanying it would have a much thinner wall, but have a larger overall diameter. I'm going to write a little tiny A in there and a little tiny V here for artery and vein. So these might be, say, the brachial artery and the brachial vein, which are the major artery and major vein in the vicinity of the brachium or arm. And they carry about the same amount of blood per unit time. But the blood within this artery is under much higher pressure and is moving much faster. And the blood that's in this venous channel is under much lower pressure and is moving much slower. So smaller diameter, larger diameter, higher pressure, lower pressure, but they're carrying almost the same volume per unit time. I say almost. Does anybody happen to know why I had to put that little almost in there? And which one of these two vessels does carry slightly more volume per unit time, but it's really an infinitesimally small difference? Bryce?
When the arteries drain into the capillary beds, don't they lose some fluid?
Capillaries leak. That's exactly what you're saying. Capillaries actually leak just a little tiny bit. By design, they're supposed to leak. And as a consequence, some of the fluid, now blood itself doesn't leak through the wall, it's just some of the water and smaller organic molecules that actually go through the wall of the capillaries out into the tissues. That excess tissue fluid then is eventually picked up by lymphatic vessels and returned eventually, of course, to the circulating bloodstream, but through lymphatic vessels on the way. So we say that out in the systemic circulation, an artery does carry just a little bit more blood than the venous channel that's running with it because of the leakage that happens in the capillary beds. Okay, let's take a look at a graphic which summarizes what we said about the aorta. The ascending aorta has two branches, the left and right coronary arteries. Remember, those supply the heart muscle itself. The aortic arch has three branches, and the descending aorta has a bunch of branches. We commonly divide the descending aorta into a thoracic part and an abdominal part by the diaphragm. So if we're above the diaphragm, that part of the descending aorta is going to be called the thoracic part of the descending aorta, and if we're below the diaphragm, that will be the abdominal part of the descending aorta. Let's go to the overhead camera for just a second. I kind of glossed over the three branches. Matter of fact, I'll bring this model back up for just a second. I do want to spend just a moment on these three branches of the aortic arch. So you can see them there. I'm going to draw them over here on our board. So we got the aortic arch coming up, and we got 1, 2, and 3 branches coming off of it. And then here the blood is continuing down the descending aorta, the heart itself, of course, located right here. Now, this first branch of the aortic arch, coming off the aortic arch, this bigger one here, is called the brachiocephalic trunk. Let me write that up here. That's its name. When you see an artery that has the last name trunk instead of such and such an artery, that typically implies that we're talking about a large vessel that divides almost right away into 2 or more smaller vessels. And indeed, this vessel does split. It divides into 2 arterial channels very shortly after it comes off the aortic arch. One of these goes on up to the head, and the other one goes out to the right superior limb. This next vessel, so let me draw an arrow over to that one. This next vessel right here is the left common carotid artery. And it carries blood up to the head. And finally, this last vessel coming off the aortic arch is the left subclavian artery. Even though we have 3 vessels coming off the aortic arch, because this one splits almost immediately into 2 different vessels, I want you to notice that basically we have 2 vessels that carry blood out to superior limbs and 2 vessels that are going to carry blood up to the head. The name of this one is right common carotid artery, left common carotid artery. This vessel is the right subclavian artery. This is the left subclavian artery. So the two branches of this brachiocephalic trunk are the right common carotid artery and the right subclavian artery. So we got two major vessels that carry blood up to the head, two major vessels from this area that are carrying blood out to the superior limbs. And then the descending aorta carries blood on down and has branches that come off it to structures located further down. Any questions about that? All right, let's, we said that veins have the same basic structure that arteries do. I want to go to a graphic that summarizes the two major systemic veins. The two biggest systemic veins are the superior vena cava and the inferior vena cava. Now you can take a look at these two names and figure out what general parts of the body they drain. Basically, the superior vena cava carries venous blood back to the heart that's been out in the top half of the body. Basically, we're talking about head, neck, superior limbs, thoracic region. The inferior vena cava is carrying blood back to the heart that's been distributed to the, quote, lower half of the body, basically abdomen, inferior limbs. And so those are the two largest systemic veins. Now, let's talk about capillaries a little bit. Let's go to the overhead. We've already said that a capillary is the smallest type blood vessel, and it's the only blood vessel that has walls thin enough for nutrients and waste products to diffuse through. Actually, the capillary basically boils down to a little teeny tiny microscopic tube that has only two tissues in its wall. And within the wall we find simple squamous epithelium. What do we mean by simple squamous when we're talking about epithelium? Anybody remember? Adam?
That it's just one layer thick.
One layer thick, that's a simple. Squamous means
Kind of a flattened out.
the cells are flattened out like little pancakes. So one layer of cells thick that are flattened out like little pancakes, then the epithelium, and then there's a little bit of CT proper that kind of holds all those flattened epithelial cells together. So a capillary is basically one of the organs in the body that only has two kinds of tissue in it. Only two kinds of tissue, and those are epithelium and connective tissue. Simple squamous epithelium and connective tissue proper. Now, if this is the direction that this capillary is carrying blood, the vessel from which this would branch from, the vessel of origin for this end, is going to be an arteriole. So there's going to be an arteriole that this capillary is going to branch off of. It's going to feed blood into the capillary. And then when the blood leaves this end of the capillary, it's going to go into a little teeny tiny venous channel called a venule. Arterioles feed blood in, venules drain blood out. So capillaries connect the smallest arteries to the smallest veins. And of course, once blood goes into venules, it goes into larger veins. Capillaries are relatively short. Blood is in a capillary for a split second. And then it's, in other words, it only takes a split second to go the full length of that capillary because of their short length. And most capillaries in the body are what we call standard or regular capillaries. But there are a couple of places in the body that have very specialized capillaries. Within the liver and a few other organs like bone marrow tissue and spleen, we have some specialized capillaries that are called sinusoids. And they have a little bit different structure than a regular capillary. And in the kidney, we have some specialized capillaries that are said to be fenestrated. They actually have little tiny holes or channels through their walls. They give them some specialized functions in those particular organs. But the capillaries in most parts of the body are what we call standard capillaries. Let's look at a graphic that summarizes some information about capillaries. They're supplied by the tiniest arterial branches, the arterioles. They drain into the smallest veins, the venules, and they are the only vessels that allow nutrient and waste exchange to occur. I really want to emphasize this last point because let's go to the overhead for just a second. Let's take a look. We'll say this is the heart, and here comes the aorta out, and it comes down here, goes through the diaphragm, and of course bifurcates down here, makes a split. We'll say that's the diaphragm right across there. If we were to analyze the oxygen content here and here and here and here, guess what? Oxygen content of the blood within that aorta is always going to be the same, because no oxygen leaves the blood through the aortic wall. The aortic wall is simply too thick. It's only when we get down into the capillaries will the oxygen level start dropping, and the CO2 obviously will be coming up, because down in the capillaries of the body, oxygen is given off by the blood, CO2 is absorbed. And just exactly the opposite is happening in the capillaries in the lungs. Seth?
Yeah, if nutrient exchange doesn't take place in that part of the aorta, how do the cells within the thick aortic wall get any nutrients?
Okay, let's go to the overhead camera for just a second. Let's draw a transverse section through the aorta. So we got blood here in the lumen. And that blood's moving real fast because the pressure's real high. What actually happens is there are smaller arteries that penetrate into the aortic wall from the outside and actually break down into arterioles and feed capillary beds in here. So the blood that's actually supplying the tissues of an artery wall, that blood does not come from the blood within the lumen of that artery. It actually comes in through some little tiny vessels from the outside. These are called vasa vasorum, which literally means vessels of the vessels. So these are the little tiny vessels that actually penetrate into the vessel wall from the outside and feed into capillary beds within that vessel wall. So that's how the tissues within the vessel wall are nourished. Amber?
So if the blood doesn't come from within the aorta, where does the vessel that goes into the aorta come from?
Okay, what's going to happen now, appreciate that this aorta has branches, right? And those branches have branches, and those branches have branches, and some of those are the little tiny branches that come in from the outside. Does that make sense to you? Yeah. So here's the point. When you're looking at a cadaver, you know, in the gross lab, and you see an artery in a particular part of the body, that artery is carrying blood from point A up here down to point B, but it is not nourishing directly the tissues that are right around it. It has to be branches of branches of branches that finally get there. Any other questions? Yeah?
I have a question on the capillaries. When you're running water through a pipe, the smaller the pipe gets, the higher the pressure is. If capillaries are so much smaller than arteries and veins, how do they keep from blowing out as the pressure goes up?
What happens is the further away from the heart that you get, Adam, the lower the, you know, when the heart's contracting up here, maybe we've got 120 or 130 millimeters of mercury during systole or ventricular contraction on the systemic side at least. As that goes through the various arteries on the way down to capillary beds, that pressure gets reduced due to friction and the fact that the total cross-sectional area increases a bit out here as we get away from the heart. By the time we get down to a capillary bed, the pressure has been reduced, say, from 120 millimeters of mercury down to about 35 millimeters of mercury. Then the blood goes through the capillary bed and enters the venules. The pressure is even lower. By the time the blood gets back to the heart, it's basically flowing with just a couple of 3 millimeters of mercury pressure total.
So even though they're smaller, there's actually more surface area in the arterial or in the capillary beds?
Yeah, there's the total cross-sectional area of capillary beds. As a matter of fact, it's quite a bit larger. Fortunately for us, only certain capillaries are open at any moment. I didn't talk about this, but right at the beginning of each capillary, there's a little smooth muscle structure called a precapillary sphincter. And those are considered to be controlled by the oxygen levels in the surrounding tissues. When the oxygen levels are reasonably high, the precapillary sphincter squeezes down, closes off the lumen of that capillary because no, quote, blood is needed in that area for a few seconds. But just within a few seconds, as the tissues in that area fed by that capillary use up the oxygen level, the oxygen is present, then the oxygen level will drop. Precapillary sphincter, smooth muscle tissue, will not be able to maintain its state of contraction. It will be forced to relax. Blood will flow in. As the blood flows in, the oxygen level will go back up. Precapillary sphincter will clamp down. So we have kind of an automatic, kind of like the traffic light control system. It's all set up. There's not somebody there pressing a button except when they have an accident. So it's all set up kind of automatic, and that's the way that it was set up physiological within our body for a lot of the capillaries. As long as the oxygen levels are high enough in the tissue, precapillary sphincters will clamp down, and there won't be any blood going in there for the moment. But in direct answer to your question now, the total surface area of all the lumens of all the capillaries exceeds the area of the aortic cross-section. Yeah. Any other questions? Well, we talked about blood pressure once before when we were talking about the heart, but let's go back and review that. We'll go to a graphic here that summarizes some comments or some points about blood pressure. It is reported as two numbers, like a typical blood pressure for a normal human being might be 120 over 70. 120 is the systolic pressure, and the 70 is the diastolic pressure. First number systolic, second number diastolic. And if we take the systolic pressure minus the diastolic pressure, that's the pulse pressure. So if you have this particular blood pressure, what's your pulse pressure? Do this math problem here. What would the pulse pressure be?
50.
50 millimeters of mercury. 120 minus 70 is 50 millimeters of mercury. You bet. Anybody, any question about that? Yeah, Starling?
Do you want that pulse pressure to be high or low, or?
Yeah, we want the pulse pressure, you want the difference to be relatively significant. That's really the most important thing. Certainly you don't want the systolic pressure to be too high, but it's critical that there's a difference between the systolic pressure and the diastolic pressure, because that's the driving force that's going to move blood through the vessels. Bryce?
So when a person has high blood pressure, is that usually the diastolic pressure that's up higher?
Can either be a high diastolic pressure or a high systolic pressure for blood pressure. We call that hypertension, high blood pressure, hypertension. There's a lot of causes of hypertension, but trying to think what else. Oh, I know something else I want to. Let's go to the overhead camera for just a second. Sometimes you'll see this in text. MSAP stands for mean systemic arterial pressure. In other words, we got the systolic pressure. I'm just going to write SP. We got the diastolic pressure, DP. Those are the two numbers. And in the one that we had 120 over 70, I think. I'm going to put this one over 60. The mean systemic arterial pressure is actually the diastolic pressure plus 1/3 of the pulse pressure. The mean systemic arterial pressure is considered to be kind of the average pressure over time. And the reason that it's the diastolic pressure plus 1/3 of the pulse pressure rather than just the average of these two numbers, take a simple average here, is because systole is a much shorter period of time in the cardiac cycle than diastole. So in other words, diastole lasts longer than systole. So the general average pressure, the mean systemic arterial pressure, is the diastolic pressure plus 1/3 of the pulse pressure. Somebody do this problem. So what would be the MSAP for this individual if this was a measured blood pressure?
80.
You bet, 80. So we'd have what, 60 plus 1/3 of 60 would be 80. Now let's take a look at what happens when somebody takes blood pressure using the old-fashioned way, where they have that cuff that's called the sphygmomanometer, the pressure cuff, and they've got stethoscope head that they're putting down here, right at the crook of your elbow. What they're doing, they puff this cuff up with enough pressure that it stops the flow going down the brachial artery. How much pressure do they have to put in? Depends on what your systemic your systolic pressure is. If you're that individual that had the 120/70, they got to get the pressure in the cuff above 120 millimeters of mercury. So if they get it at 130, it's going to be so tight that it's actually going to stop blood flow down through the brachial artery. What will they hear when they listen with their stethoscope down here at the crook of the elbow? Nothing. Not anything at all. Then what they do, after they puff it up to where they can't hear it, they start bleeding the pressure off. They start turning the valve and letting the pressure slowly drop. When the pressure gets down to 120, a little bit of blood will squirt through that brachial artery. The flow will be turbulent. You'll be able to hear that down in the stethoscope. And then you take a look at the pressure as it's dropping. When you hear the first choric cough sound, it's called, when you hear that first noise, write that down. That's going to be the systolic pressure. That's what the pressure was going to be in the cuff when it first started squirting through. Then, as any time between 120 and 70, you're still going to hear those choric cough sounds because there's going to be turbulent flow of blood a little bit. But then when the pressure gets down below in the cuff, gets down below the diastolic pressure, you won't hear anything again because it'll be nice, smooth, laminar flow. So when you first hear the choric cough sound, that's going to be systolic pressure. When you hear the last choric cough sound, whatever the pressure cuff reads at that time, that's going to be the diastolic pressure. Starling?
Do they do that on the break-in because it's the closest to the heart? Could you do that further down, or would it be harder?
It turns out to be a real handy place. I think there are some other places in the body that can be used. Certainly, I don't think we want to use it around the neck, you know, but it is a very convenient place. And that's the classic place. Now, they got some automatic sphygmomanometers now. They just put it on, and the machine does it all. And so you don't have to stand around, you know, with the stethoscope and check for the noise and so forth. Bryce?
I've seen on some individuals they'll actually put the cuff around the antebrachium, and then they'll listen for their pulse down
Sure.
lower.
That's what I guess Starley was asking about just a second ago. Let's talk about some of the factors that are related to blood flow. Let's go to the overhead camera for just a second. We've got a blood vessel here. How do you suppose that length? In other words, I got a shorter vessel and a longer vessel. I got the pressure the same, the vessel's the same in diameter and so forth. What's length going to play a role? We're going to have more blood flowing in this longer vessel or less blood, do you think? Actually, if the diameter of the vessel is the same and all other factors, there's going to be more resistance in here because more friction. So the longer a vessel, that tends to reduce flow. What about size of a vessel? I got a smaller vessel and a larger vessel. Let's make them both the same length now. Okay, so the same length, the only difference is size. Which one of these two vessels is going to carry the most blood per unit time? All other factors being the same.
The smaller one?
Let's see. I got X amount of pressure here, same amount of pressure here. The larger one, yeah. The larger vessel is going to carry more. I want to tell you, it's kind of interesting. Let's suppose that this is 1 centimeter in diameter, and this one's 2 centimeters in diameter. Does anybody happen to know what all factors being considered? You double the diameter of a vessel, what kind of a factor does that have on the amount of blood it'll carry, all the other factors being the same?
Factor of 4?
Actually, it's not even 4, it's 16. A vessel that's twice as large, it's the radius to the 4th power. Double the size of a vessel, and that bigger vessel that's twice as big in diameter will carry 4 times as much blood, other factors being the same. We can go to the viscosity of the blood. Viscosity of the blood. What do we mean by viscosity?
Thickness.
How thick blood is. Are we talking about somebody that's anemic and has watery blood? Or are we talking about somebody that's dehydrated and has very thick blood? If the viscosity goes up, what's that going to do to the amount of flow? All other factors being the same. It's going to go down. It's one of the reasons why dehydration can be very severe, because it's putting a real load on the heart. It's hard for the heart to pump real thick blood through the blood vessels. Yeah, Adam?
While we're on that, because of the leak in the capillary beds, does that mean that venous blood's more viscous than arterial blood?
Slightly, but the total amount of leakage of fluid that we were talking about in capillary beds is so small that there's not a significant difference in the viscosity. Good point, though. Anyway, these are some of the factors that influence blood flow, and there's a number of others as well. Certainly, the amount of pressure difference between the top end of the vessel and the bottom end of the vessel is a factor in that as well. Let's go to a graphic here that summarizes some of the different kinds of cardiovascular shock. First of all, what do we mean by cardiovascular shock? Sometimes we just say this person's in shock. You know, there can be emotional shock too, although cardiovascular shock can be a part of severe emotional shock. Adam, what do we mean by cardiovascular shock?
It's a significant decrease in blood pressure.
Significant decrease in blood pressure. So I could get that if I lost a lot of blood, and if I'm in shock because, in other words, if my blood pressure goes down significantly because I've bled out a lot of blood. You know, Mom said not to stick your arm out of the car because it would get torn off by a mailbox or a tree, and sure enough, that happened. So I'm a couple quarts low. That's called hypovolemic shock. If the problem is the heart itself, and the heart's just not pumping correctly, maybe it has gone into what we call fibrillation, where different parts of the heart are contracting at different periods of time. It's not contracting in a coordinated manner. That could be cardiogenic shock. Neurogenic shock is where you have autonomic nervous system influences on the smooth muscle of primarily muscular artery walls, and too many muscular arteries are dilated at the same time. If you dilate too many vessels at the same time, then the pressure is going to go down. In other words, you make too many vessels larger in cross-sectional area, blood pressure will go down. Endotoxic shock is a special case of cardiovascular shock where we have a bacterial infection, and some of these bacteria are producing toxins that are paralyzing those precapillary sphincters. Now remember the precapillary sphincter. Let's get rid of that graphic for just a second, go to the overhead camera. Here's the capillary with that little precapillary sphincter around it, little smooth muscle sphincter. Of course, that's feeding off an arteriole here. Okay? And if the precapillary sphincter, sometimes they're clamped down and don't allow blood to flow. Sometimes they're relaxed and do allow blood to flow. But in certain endotoxic situations, bacteria can produce poisons that paralyze these precapillary sphincters. Too many precapillary sphincters relaxed at the same time would mean too many capillaries open at the same time. And what happens to your water pressure when everybody on your block turns on their hoses at the same time? It goes down. And maybe you don't get but a trickle if you're down at the end of the block. So that's what happens in endotoxic shock. Just wanted to make sure that you knew when we talk about shock, that's the kind of thing we're talking about. Significant drop in blood pressure. Now the dangerous thing about shock is that the brain does not receive adequate perfusion of blood. Brain's a big user of oxygen, one of the largest users of oxygen in our whole body. And whenever we go into a situation where we have very, very low blood pressure, inadequate amounts of blood can get to the brain. And the brain then can be damaged. Let's go to a graphic that summarizes what we mean by a standard circulatory scheme. By this, we're talking about starting at the heart, blood leaves the heart in a large artery, a single large artery, which has branches, and they have branches. Finally, we get down to arterioles, and blood feeds into the capillaries. Leaving the capillaries, the blood goes into venules, which feed into larger veins, which feed into even larger veins, and finally we get back to the heart. Now, it doesn't make any difference whether we're talking about systemic circulation or pulmonary circulation. This general pattern is the same. I want to distinguish this standard circulatory scheme from what we mean by a portal scheme. Let's go to this next graphic and see what we mean by a portal scheme. Starts out the same. Start at the heart, big artery, smaller arteries, get down to capillaries, so all that initial part's the same. We go into venous channels, may even get clear back up to ones that are big enough that we can call veins, but then we go into a second capillary bed, another capillary bed in some other part of the body. And then we go drain out of that into venous channels again, and then eventually go back to the heart. The significance here is that we have two different capillary beds, a first capillary bed and a second capillary bed. And that's very rare that we have circulatory schemes that are of this portal nature. Matter of fact, there are only two of them in the whole body. On this next graphic, we can see their names. One of them is called the hypothalamo-hypophyseal portal system, and we talked about this one very briefly when we talked about the endocrine system in a previous session. And the other portal system is called the hepatic portal system, and that involves venous blood from various digestive organs and other abdominal organs, in fact, that drains into the liver, where it goes through a second capillary bed in the liver, and then that blood is finally returned to the heart. The purpose of that first one, the hypothalamo-hypophyseal portal system, seems to be to carry certain hormones from their site of production down to the anterior lobe of the pituitary gland, where they act. The functional purpose of the hepatic portal system seems to be to allow the liver to metabolically modify and detoxify certain things that have been absorbed from the alimentary canal. And we will talk about that one more when we talk about the digestive system itself. I've got an interesting graphic here that shows the distribution of blood in various parts of the cardiovascular system. Take a look at this. About 2/3 of the blood is actually in the systemic veins at any given moment. Now, we have about, if we're an average-sized person, we have about 5 liters of blood in our body, okay? It's about 1.5 gallons, okay? Roughly 1.5 gallons if we weigh about 150 pounds. 65% or 2/3 of that is within, at any given moment, within systemic veins. 13% of it's in systemic arteries. 9% of it is in pulmonary circulation. 7% is in systemic capillaries. And only 6% of it at any given moment is in the heart. Any questions about any of those things? Yeah, Adam?
Do some of the large organs like the liver account for a large percentage of that 65%
Yes.
in systemic?
Mm-hmm. Liver, skeletal muscles count for quite a bit. A lot, in fact. Seth?
I was wondering if you could describe exactly what's happening when a person has a heart attack.
Heart attack. All right. Let's write that up here. Go to the overhead camera for just a minute. What's happening here is that blood flowing through some of the vessels that supply the heart muscle. Remember, coming out of the ascending part of the aorta, we had 2 large arterial channels called the left and right coronary arteries that came off and supplied the heart itself. If either of those 2 channels or some of their significant branches that supply heart muscle tissue are clogged up significantly, the amount of blood flow to a certain segment of the heart wall will be significantly compromised. And that tissue, receiving inadequate amounts of oxygen and other nutrients, that tissue will undergo what they call ischemic necrosis. It'll die. And so when we talk about a heart attack, we're talking about segments of the heart wall that actually are in severe trouble, primarily oxygen-wise first, and they're dying because they're not receiving adequate amounts of blood flow to them. Now, the thing that typically causes this inadequate blood flow is buildup of plaques of primarily lipid materials in the tunica intima of those vessels, and so we get more and more. Let's say we eat bacon every day of our life, you know, and our idea of a good dinner is, you know, an ear of corn with 3 or 4 sticks of butter on that one ear. Okay. High lipid, extremely high lipid intake dietarily has been related to the buildup of some of these kinds of plaques within the tunica intima, which basically makes these vessels have smaller and smaller and smaller diameters from a functional standpoint. It's kind of like the old, some of the old lead pipes that some of the houses had would get more and more buildup of minerals inside of them until finally they weren't carrying hardly any water at all. And when these major vessels supplying heart muscle tissue are severely compromised by that kind of buildup of plaque material, then we get a significant chunk of heart wall that's receiving inadequate oxygen, and it dies. And then the heart fails to contract properly. There's pain associated with that. And unless we can get that under control right away, it can be, if it involves a significant part of the heart, it can even be fatal. Any other questions? Starley?
I know that when people do have a heart attack, they put a balloon in, and I assume they're just opening those up so that they're allowing the oxygen to go through. Are they actually taking some of the lipid material out? Because it would.
They usually don't do surgery to remove the lipid material, but you're right about the little it's plasty, what we do? Angioplasty, yeah. They put a catheter in that has a little inflatable balloon on it, and basically they're going in there, blowing that balloon up. They're basically saying to the lumen, open back up, and they're forcing. You ever had a sock that was so tight that you had to stick a fist in it before you get it over your foot? Okay, okay, now I think I can get my fat foot in this thing. The other medical procedure that's used, my dad had one of these a few years ago, is what we call bypass surgery, where they'll actually take and sew vessels around the clogged area. They'll attach them up here, sew them in up here, and bypass that particular area. It's kind of like when you got a, you've been going down the highway and they've detoured you because they're working on that bridge. You got to go down this way and around to continue on your route. Same thing. So they can do it either way. On the milder cases, they can do the angioplasty thing and sometimes get adequate opening of those vessels, and in the more severe cases, they may actually have to do bypass. When they talk about a double bypass, a triple bypass, a quadruple bypass, they're talking about how many clogged places that they went around surgically. Any other questions while we're talking about circulatory things? Yeah, did you have another question?
Sorry, I know that you just said quadruple because of how many were clogged, but there was only 2 coronary arteries.
Yeah, but each of those has many branches. The bigger ones are named and the smaller ones aren't. And we're talking about in this whole scheme of vessels coming off those 2 initial branches, how many places in all of these, in all this arborization did they actually sew bypass vessels around? That's what we mean by that. Okay? Next time I want you to read the section on fetal circulation, and we'll talk about blood a bit. Okay?